The clinical implications, why is it important to understand this relationship? So these are the clinical implications for risk assessment. Patients with diabetes, they require more aggressive risk assessment regardless of traditional risk factors. And this includes things like obesity, sedentary lifestyle, family history of diabetes, things like that. So as long as you have diabetes, it requires more aggressive cardiovascular risk assessment to reduce your long-term risk of getting cardiovascular disease in future. And you can see here from the ADA guidelines in 2025, there are 4 planets to reduce diabetes complication. So it's not just about glycemic management, sugar control, it's also about blood pressure control, cholesterol control, and also using agents that have cardiovascular and kidney protective benefits. And patients who have cardiovascular disease, they should also be screened at least yearly for diabetes and pre-diabetes. And risk assessment tools must account for this interconnected bidirectional relationship. And treatment strategies also should address both conditions simultaneously rather than in isolation. So these are some guidelines according to the American Diabetes Association, European Society of Cardiology, and also American Heart Association. So the common the common thing about these guidelines, even though they can be a little bit different in the nitty-gritty details, the common thing is that they consider diabetes as a high-risk condition, especially if you have it for more than 10 years already. So then you have to automatically just class these patients, categorize them as high-risk category, and then treat them accordingly. And the thing also is to have mandatory screening for diabetic nephropathy. So you check the EGFR, you check the albumin creatinine ratio, and you check for the eyes and the feet for that patients with diabetes at least annually, because these are all cardiovascular risk modifiers. But despite established guidelines, significant gaps still exist between recommended cardiovascular risk assessments and the implementation in primary care. Studies indicate that up to 40% of diabetes patients receive suboptimal cardiovascular risk evaluation. This leads to missed opportunities for preventive intervention. So I'll share with you a few risk classification tools. I don't think that we should localize it in one's context because there are many out there, well, a few out there, but it has to be very individualized to the population because they use population health data. So one population may differ from another population. So the first one is this ASCVD Risk Estimator Plus, and this is for primary risk scoring. So for patients who've never had any cardiovascular disease before, asymptomatic. And this estimates your 10-year risk of getting a heart attack or stroke for asymptomatic men and women. And this is usually validated for the below 5%
Recording in
of
progress.
getting any kind of adverse cardiovascular outcomes within the next 10 years. Intermediate risk will be between 5 to 20%, and high risk will be more than 20%, or they already have established cardiovascular disease. So in this case, ASCVD actually doesn't just refer to a heart attack or a stroke. It can even mean peripheral artery disease. It can even mean aortic atherosclerotic disease as well. So that's important to know. It's not just a heart attack or a stroke. So this is a summary of the risk management for patients with type 2 diabetes. So we stratify according to the risk calculators that we have, and depending on your local population, you will use your local risk stratification tools. Once we do that, we may perform further risk assessment if it's considered to be maybe intermediate or high risk. We perform further assessment using an ECG, an ABPI, ankle brachial index, for especially if we suspect peripheral artery disease, or we can also do a coronary calcium scoring as well to further risk stratify these patients. And then once we have done that with the results, then we manage accordingly in those with high risk or those who already have cardiovascular disease. So we can use the new kids on the block, the GLP agonists, or we can use the SGLT2 inhibitors as well, with or without metformin. And we will go into more detail about these two medications later. So the GLP-1, the GLP-1 receptor agonist, this is a meta-analysis composing of 8 trials and over 60,000 patients. And these investigators were encouraged to manage participants according to their local guidelines. And everybody in these trials, the median age is about 60 to 66 years old, which is about the age, to be very careful to, not get cardiovascular disease. So the 3-point major adverse cardiovascular event actually includes cardiovascular death, non-fatal MI, and also non-fatal stroke. And they found that GLP agonists actually reduce all-cause mortality by 12%, hospital admission for heart failure by 11%, and the kidney outcomes, means kidney progression, by 21%. And there is no increased risk of severe hypoglycemia, retinopathy, or even pancreatic adverse events. So the cardioprotective effects of GLP-1 agonists cannot be disputed, and this represents an important treatment opportunity to reduce morbidity and mortality in patients with type 2 diabetes. SGLT2 inhibitors, on the other hand, so they also looked, this is meta-analysis composes 6 trials, about 4,900 patients, just shy of 5,000 patients, and about 81.6% of them, they actually have MACE outcomes. So MACE outcomes in this case will be MI, myocardial infarction, stroke, or cardiovascular death. And they found that overall, SGLT2 inhibitors significantly reduce the risk for MACE, but that's about 0.9. So the effect is quite modest, actually. The overall pool estimate is modest, but it shows there is still some benefit in in having SGLT2 inhibitors for our patients. And this is usually shown in the SGLT2 inhibitors of empagliflozin and canagliflozin. So we have to be careful. There are certain types of SGLT2 inhibitors, not all, that actually can reduce your risk of MACE. If we look more closely into hospitalization for heart failure and kidney-related outcomes or kidney progression, you can see that the overall pool estimate is actually a lot more to the left of the line. So that means the hazard ratio is a lot less. So the risk reduction is actually a lot more and very consistent across all the trials, and they show that it's actually very favorable, specifically for hospitalization for heart failure and for reducing kidney progression. So this is actually really good for our patients, not just to lower glucose control, but also to protect in terms of long-term risk management. So being a lifestyle medicine physician, it would be remiss of me if I didn't mention anything about lifestyle medicine. So as you can see from my first few slides, the pillars of the how to reduce diabetes complications, at the bottom there, if you notice on the steps, the foundation is still lifestyle management. So that is something that we should not forget. And in lifestyle medicine, we have 6 pillars, which is nutrition, and we emphasize a predominantly whole, very minimally processed food, diet, adequate physical activity. So it's not just about exercising, but as long as you get up and you move around, physical, be regularly physical. That is the idea. Restorative sleep. Sleep is important as well, because studies we all know, we have shown that a lack of sleep increases our risk of chronic inflammation and long-term risk as well of metabolic syndrome. Reducing stress, relaxing, Having a positive mental attitude also helps. And then the fifth pillar is positive social connections. We build relationships, we build networks that can improve our physical and mental health. And the last pillar will actually be avoiding risky substances such as alcohol, smoking, and also drug consumption. So this is according to the ADA guidelines from 2025, very updated. So this shows the lipid management for primary prevention of CVD in patients with diabetes, in addition to healthy behavior modification as well. So in below 40, we are advised to consider statins if there are additional risk factors such as high blood pressure, smoking, obesity, and things like that. For those between 40 to 75 years old, we're encouraged to use moderate intensity statins. And for those with more than one CVD risk factor, we're encouraged to use high intensity statin. So that includes atorvastatin or rosuvastatin even to achieve the target of below 1.8. We may or may not want to add ezetimibe or the PCSK9 inhibitors just so we can achieve this target of 1.8, which is actually really low and something that I get a lot of backlash from my patients because this is very low for them. They feel like it's very unreasonable, but it actually has been shown to, have benefits. So I think that's something that we should encourage our patients to try to achieve towards. And those who are much older, above 75 years old, we are encouraged to continue this therapy or consider a moderate intensity statin. Okay. And then the ADA guidelines also mentioned about secondary prevention of cardiovascular disease. So once somebody already has established cardiovascular disease, how do we prevent? The target for cholesterol management actually goes down even lower to 1.4, or we have to reduce the LDL by 50%. And this is done by using lifestyle management and also high intensity statins, like I mentioned earlier. And we may or may not add ezetimibe or the PCSK9 inhibitors as well to achieve this target. So in summary, diabetes control centers around long-term risk management. So it's not just about lowering sugar levels, HbA1c. There is this bidirectional relationship that we need to appreciate and understand between cardiovascular disease and diabetes, because as the burden of cardiovascular disease grows, effective risk stratification is not just beneficial, but it's very essential for optimal patient outcomes as well. And there are many risk stratification tools that we can use, but it's important to localize to one's context. So novel agents as a cornerstone of diabetes and CVD risk management. So these would include your GLP-1 agonists and also the SGLT2 inhibitors, depending on the outcomes that we want to achieve, whether it's kidney progression, hospitalization from heart failure, and things like that. So the key takeaway here is to risk stratify our diabetes patients. Always use, as much as possible, we try to use the risk stratification tools when we diagnose somebody with diabetes or when we follow up our patients with diabetes. So with that, I share with you my references, and thank you very much for your time.
Yeah. Yeah, thank you very much for the Dr. Sharifa. I am the Dr. An, the chairman today. I'm so sorry about the late due to the traffic jam. And one more time, thanks for your wonderful presentation of Dr. Sharifa. Let's move to our second polling question related to this session. Which factor do you consider the most challenge when assessing cardiovascular risk in patients with type 2 diabetes? You can select the option. we have only one single choice. I remind all of you. Uh-huh. Now, I look at the poll. We have the highest selection for the lack of the patient adherence to recommended the lifestyle changes. It's very good point. I think that all of us, we will face the same issue. The second one is the limited of time for comprehensive risk assessment. It's reasonable for all. Osmot in low middle income country with very crowded patient every day. And the last one is the limited access to investigation, only 9%. And the lowest is the difficulty in applying risk calculator in daily practice, 7%. Two of them will be a barrier for our working. And now I would like to move to our next speaker. I have presented Dr. Lê Thanh Toàn from Vietnam. He's a family physician and lecturer from University of Medicine and Pharmacy at Ho Chi Minh City. Dr. Tuan will be speaking on prevention and early detection of chronic kidney disease in newly diagnosed type 2 diabetes patients in primary care. Dr. Tuan, please go ahead. Thank you.
Sorry, thank you. Good morning, everyone. Good morning, Professor An. Glad to see you today to join with us. Good morning, all the esteemed panelists. It is truly an honor to join this webinar. This available opportunity to discuss the importance of early screening and prevention of chronic kidney disease in patients with type 2 diabetes in primary care. It is a crucial topic and an early intervention can make a significant difference in long-term outcome for our patients. My presentations will cover three main objectives. First one, to highlight the importance of early screening in newly diagnosed patients with type 2 diabetes. Second, to provide updates on current guidelines for the management of diabetes kidney disease in primary care. And the last one is very important and interesting to illustrate this concept through real clinical case from our practice. The prevalence of diabetes in Vietnam is increasing rapidly. This growing trend presents a significant public health challenge. It may lead to serious long-term consequences for our healthcare system and population. On the screen, you see there's a number of people with diabetes. It's rising every day. Today, about 537 million people worldwide are living with diabetes. However, less than 50% of patients achieve their treatment target, defined as hemoglobin A1C below 7%. And in addition to diabetes, many patients have society's risk factors such as obesity, hypertension, hypercholesterolemia, and cardiovascular disease. In particular, chronic kidney disease is a major concern, affecting about 50% of people with diabetes. Vietnam has a high rate of diabetes compared to other countries in the Asia Pacific region and globally. From 2017 to 2045, estimated the prevalence is projected to increase by 78.5%, meaning the number of people with diabetes in 2045 will be nearly double that of 2017. Unfortunately, only about 31% of cases are diagnosed, leaving nearly 70% undiagnosed. Among those, only 34% suffer cardiovascular.
Đây là đôi găng tay bảo hộ không thể thiếu trong nhà các bác mỗi lần thấy em bé đứng một mình ngoài cổng, các em học sinh liền có hành động đẹp, thì ra đây là dáng hình của những đứa trẻ được giáo dục tốt. Trong cuộc sống hiện đại, khi những điều tử tế hay tình làng nghĩa xóm đôi khi bị chỉ 15 phút mỗi ngày giảm đập.
According to statistics from Ministry
Recording in progress.
high-risk security is associated with increased risk of cardiovascular events and deaths, as shown on the slide. Patients with reduced kidney function can have up to 5-fold higher risk compared to those with normal eGFR. Early screening for CKD in patients at risk in primary care setting.
Have to know when Nicolon is in the front row as a blocker, but also when you want to attack the nowhere near where the play was.
Bạn tắc đẩy ống thắt lưng. Vì sao Tổng thống Brazil đặt niềm tin vào Việt Nam thay vì lắng nghe Trump tại Liên Hợp Quốc? Thế giới chấn động.
Khi lấy đúng người thì bạn sẽ mãi là đứa trẻ. Đây có lẽ là hình ảnh hạnh phúc giản đơn mà ai cũng mơ ước có được. Khi lấy đúng người, bạn sẽ luôn được sống trong cảm giác an yên và hồn nhiên như một đứa trẻ, không cần xa hoa hay cầu kỳ. Hạnh phúc đôi khi chỉ nằm trong những khoảnh khắc đơn giản, vợ chồng vui đùa ngoài sân, người vợ cười khanh khách khi được chồng cõng trên lưng, hay hồn nhiên ngồi trên hỗ trợ ô tô đồ chơi của con, để rồi chồng chiều chuộng món cho ăn. Hình ảnh ấy khiến ai nhìn vào cũng phải mỉm cười, bởi sự hạnh phúc vốn dĩ không cần phải phô trương mà chỉ cần tình yêu chân thành. Có lẽ đó cũng chính là giấc mơ thầm kín của biết bao cô gái.
Recording in progress.
And you are C8 or
Recording in progress.
and EGFR. On the screen, you can see the numbers 1, 2, 3, 4, and more. It depends on the what stage of kidney disease and how many albuminuria in albuminuria. Even when the EGFR are normal, the presence of albuminuria greater than 30 milligram per gram is still sufficient for diagnosis of CKD. Similar to the recommendation of ADA and KDIGO, the Vietnamese Ministry of Health also recommends that on patients with type 2 diabetes should undergo early screening for kidney function using estimated glomerular filtration, EGFR, and urine albumin to creatinine ratio. You can see on the screen. The mortality rate is proportional to age and UICR level. On the screen, you see on the populations have higher mortality rates, especially when the UICR levels are elevated. This means that risk of mortality depends not only on EGFR levels, but also on UICR levels. This again to confirm that albuminuria is very big information for our practitioner. Treatment of diabetes chronic kidney disease. We can see, look at this slides. I summarize the guidelines from 2017 to 2025. We can see that treatment goals have evolved over years from 2017 to 2025. In 2017, the focus was on controlling blood glucose levels. However, today, the approach has shifted. We no longer focus solely on glucose control, but also aim to avoid hypoglycemia and to prevent cardiovascular and kidney complications and weight loss. This means that
có người đủ tháng rồi á, họ để xong họ ăn uống, nói chung là ăn uống nhiều thứ rồi, không cho bị uống. Còn mấy cô mới sinh mới đẻ, tức là anh đọc bé Thư đi khắp mọi nơi nào có sữa mẹ là anh cứ đọc tên sinh cho bé Thư uống. Đấy. Trời.
Recording in progress.
Cardiovascular complications. The second recommended medication is a GLP-1 receptor agonist. When SGLT2 inhibitor
Tùy tên.
Recording in progress.
GLP-1 as the alternative, especially for patients with type 2 diabetes who have a kidney or cardiovascular disease. According to IDA 2025 guidelines, in patients with diabetes and chronic kidney disease, SGLT2 inhibitor recommended as they not only improve glycemic control but also slow the progression of CKD and reduce risk of cardiovascular events is a strong recommendation. That it is chronic kidney disease recommendation by ADA 2025 and ADO 2024. Metformin can use for treatment of diabetes, but its use depends on eGFR level. If the eGFR is below 30 milliliters per minute, metformin is contraindicated. In the case where metformin is contraindicated, GLP-1 receptor agonist can be used as therapy. And Cardigo 2024 recommendations, similar to IDA, the Cardigo 2024 guideline recommend use of SGLT2 inhibitor in patients with chronic kidney disease. It is a strong recommendation with high evidence. And to earlier initiation of SGLT2 inhibitor delays progression to end-stage kidney disease. To measure study show that DAPA CKD or EMPA kidney demonstrated earlier use SGLT2 inhibitor in patients with diabetes at the risk of CKD can delay progression in 7.8 years for EMPA kidney or EMPA glycogen and 12 years for the DAPA glycogen. But one point is very important when we refer the patient to the specialist. We should refer patient to specialist. Is recommendation by Cardigo 2024 when the disease progress rapidly without clear cause and when the patient is in the advanced stage. Most patients with chronic kidney disease should be managed by primary care providers or family physicians. This approach helps save time, reduce healthcare costs, and allow for continuous and follow-up. As you know, in our society today, the number of specialists is limited. That's why primary care physicians who are more access.
Con ơi, con về đi buổi nắng. Rồi về đi rồi bác nói lý do chưa có được. Để chiều đã con về đi rồi bác điện cho con. Chắc phải tối để bác bàn với con lại coi sao lại. Nghe.
Recording in progress.
Treatment. And last one, develop a plan for continuity care. It's our test we order to do for the patient. You see on the screen the results of test. Here a little bit, we can see fasting glucose, not so much, right? Hemoglobin A1C 7.1, not so high. But one thing I want you to think about is the albuminuria, because
Hi, Dr. Toàn, can you increase the volume? The voice is so difficult to hear from us. Yeah, thank you.
Thank you. I will slowly. In the test we ordered for the patient with that in the urine present of albumin. Yes, for heart detection, we ordered the echocardiography and ECG. Every test are normal. Only one thing we can see is albuminuria. The patient have diabetes only 3 years ago. Before initiating treatment, we need to assess the patient's risk factor. To estimate the risk factor in Vietnam, we can use score, DSM score 2, score D, or score OP international scale. But in Vietnam, we use score VN or Caribbean, which is accepted by Vietnam Heart Association for use in primary care system. The Caribbean risk assessment tool will be presented in detail by Professor An after the presentation.
Thầy Toàn ơi, thầy Toàn mở volume lớn lên giùm thầy Toàn. Okay. Bên đây khó nghe quá. Okay.
Hello.
Yeah, this is okay. Thank you.
It's okay, thầy An.
It's much better. Thank you.
Sorry.
We continue, please. Yeah.
Sorry, I continues. After we use Kerami tool for assessment risk factor, we see on the screen the patient have very high cardiovascular risk and kidney risk at the risk of developing kidney disease. The LDL-C cholesterol goal must be less than 1.4 millimole per liter, and systolic blood pressure below 130 millimeter mercury. And what we need to do for the situation, we continue the previous treatment or maybe change. In the previous prescription, we was using metformin dose of 2000 milligram. So in this, we see the patient has albuminuria, and so we have to change a little bit. We switch metformin 2000 to 1000 milligram combined with the SGLT2 inhibitor. In this case, we use to improve adherence, we use combination pill to make it easier to take for the patient. Yeah. The second one, we have access to the risk factor. The statin therapy should be switched to high intensity regimen, because before the patient used atorvastatin 20 milligram, it is a moderate intensity therapy. We have to switch to high intensity therapy using rosuvastatin 20 milligram. After 3 months of optimized treatment, we observe an improvement in all parameters. Here we can see the reduced albuminuria, reduced BMI, and hemoglobin A1C less than before 7.1, and today 6.7%. And if the treatment goal is not achieved after 3 months, we will switch from sulfonylurea to GLP-1 receptor agonist, because today GLP-1 receptor agonists not only reduce the glucose, but it also they reduce the waste. And so my summary, there are 4 points. Early identification of CKD in primary care, you can use eGFR, and urine albumin to creatinine ratio is important, no change. SGLT2 inhibitor, a cornerstone in diabetic kidney disease management, and GLP-1 receptor agonist, an option for patients with cardiorenal metabolism. And last one is very important, earlier initiation of SGLT2 inhibitor delays progression to end-stage kidney disease. Thank you for your attention. Thank you.
Yeah. Thank you for both our speakers for those insightful presentation. We will now open the floor to your questions. Please submit them via the Q&A panel. And we have to take a poll question 3. In your practice, what is the biggest barrier to early detection of the sick? Now, we are very happy that we have the summarize of your answer. The first barrier, 40% of your selection is the patient not coming for regular follow-up. Usually we have to meet with this situation when people in rural area. I agree with you. The second one, 17% is the lack of routine screening. For example, urine, albumin, EGFR. Yes, we almost think about it then in the rural area or small in community health center. And 50% of us, we think about the cost or availability of tests. Yes, if we belong to the community health center or primary care level. And the third one is 28 limited awareness among patients about security risk. Yes, that's the biggest issue we deal in low middle income country. Thank you. And now, I'm very happy to welcome our panelists who will be joining with Dr. Sharifah and Dr. Tuan today. I would like to introduce Professor Dr. Jen J. Matawarn. He comes from the Department of Faculty Medicine, Department of Medicine, Faculty of Medicine and Secretary, University of St. Thomas Hospital, Manila. Welcome to Professor Dr. Anis Shafura, the Professor of Family Medicine, the Deputy Dean for Research and Innovation, University of Technology, Mara, UITM, Malaysia. And welcome to Dr. Debash Basu, the Senior Consultant in Diabetes and Preventive Cardiology, Apollo Clinical Multi-Specialty Hospital, the Medical Director of Helios Global, India. And welcome to Dr. Marshall Tindin, Assistant Professor, Department of Internal Medicine, Yukida Faculty of Medicine, Jakarta, Indonesia. We now move on to our panel discussion and Q&A session. Please to continue submitting your question through the Q&A function. I will address as many as time allow. Yeah. Yeah, we start of the first question. What is the only reason to stop statins? I would like to invite Professor Sharifah handle this first. Thank you.
Okay. So the only reason to stop statins, I would think, is allergy or intolerance to statins. In my personal primary care experience, I try not to stop statins as much as possible unless the patient, especially for patients with type 2 diabetes, because of the relationship with cardiovascular risk outcomes and the long-term risk benefits. So really only when a patient is unable to tolerate or they're allergic to statins, then we'll stop, and then we'll try to switch to another agent that can help to achieve the LDL targets.
Yes, thank you, Professor Sharifah. And we know that we have, we cannot stop. We have balance between the benefit and the harm from our target. The second one.
Prof. Pham, if I may add to that question on statin.
Yeah, thank you. And I would like to invite Professor Anis. Yeah.
Thank you. With regards to statin, I think we have to remember that the most serious complication of statin, it could be rhabdomyolysis when the patient's muscles start to break down. Even though there is no recommendation to check for the patient's creatinine kinase level regularly, but if the patient is actually complaining of muscle pain, we have to check their CK level and to see whether there is raise in CK level. So, of course, if there is one, then we should stop immediately, and then probably look for alternative. Or maybe you can try another type of statin where patient can tolerate better. But I've shared in the Q&A there, even though there is no raise in CK, if the patient is still complaining of muscle pain, then we should try to change to another statin until we exhaust all the choices. Then look for other lipid lowering agents. So those are the, I think, would be beneficial to share in my experience in my clinical practice, and as well as recommendation by our Malaysian clinical guidelines, because we have a new one just released into 2023. So I've shared the reference as well, especially for the Malaysian participants, and of course for the other participants in other countries as well, because our Malaysian guidelines is evidence-based, is we appraise evidence from clinical trials and all over the world. Thank you. Thank you, Prof.
Thank you, Professor Anis.
I'm Devashish Basu from Calcutta.
Yeah,
allow me?
Yeah.
So the thing is, I would like to add, if you allow me, that
yes, please.
if is it of use to write a statin regardless of type 2 diabetes to a person above 85? So that is a big question, that because we have an increasing elderly population here, the fall, sarcopenia, etc., and as ma'am said about the muscle involvement, not going to that extent of rhabdomyolysis. And one more important point is, when we're talking about CKD, the ESRD, the dialysis, there is something called inverse epidemiology. As your blood cholesterol, the numbers go down, as your blood pressure comes down, as you become very lean, sarcopenic, your mortality increases. Inverse epidemiology, so reverse epidemiology. So this inverse correlation we have to also keep in mind as we are doing our own individualized practice. This is purely gut feel.
Yeah, thank you, Dr. Dipanish. I agree totally with the both of our panelists. We have to focus in our patient with type 2 diabetes, because I will recommend to them they have to take the exercise. And for some of them, they follow very heavy exercise, look like the PT. And for them, for this group, we have to consider carefully some risk factor for using statin. Yeah. The second one, we have to work with another group, look like Dr. Dipanish recommend. Yes. but we have to balance between the harm and the benefit, and we change the statin according to Professor Anis. Yeah.
Professor An, can
Thank
I add
you. Yeah, Dr.
regarding
Mark.
statin?
Yeah, please.
Yeah,
Yeah, go ahead.
thank
Yeah.
you. I'm just adding what Professor Anis and Dr. Dabas
Yeah.
add a few months ago. I have a case, old lady consumed statin for quite long time. She had suddenly weakness, not in pain, but weakness, which it was an antibody to HMG CoA reductase, which not so commonly found in all patients. So the patient is come with muscle weakness in both extremities, and we diagnose the patient from EMG. In such cases, we had stopped the statin and changed into another more tolerable uh, therapy like PCSK and newer regimen we have. And the other thing we have to uh, careful about statin, in terms of combination with ezetimibe. If I have a patient with use statin for quite long time for CAD, we combine with statin, and what happened is severe myositis, like Dr. Aziz, Prof. Aziz mentioned before. His CK is increasing. He has kidney failure, and we need to stop the medication and change and another regimen which can be tolerable. New regimen case quite tolerable, and we can have it for the patients. And the other issue is statin withdrawal. We need to very cautious about stopping statin, because as fast as 3 days with stopping statin, the LDL level or underlying lipoprotein will suddenly increase, and it will go give harm for the patient. So we need to replace statin accordingly, according to risk factor. Thank you.
Yeah, I would like to invite Dr. Ben. Yeah.
Yeah. So I do agree with the comments on statin safety, but I have to say that those complications, especially rhabdomyolysis, is more rare than common. So I don't want the audience to actually be fearful of statins. I do agree that statin-induced myopathy or SAM is relatively common, but that SAM is not rhabdomyolysis. Okay,
Yeah.
so Professor mentioned earlier that you can actually change statin, and there are recommendations that you can do what you call a de-challenge, re-challenge, wherein you stop the statin, and if the distribution of the pain for the statin-induced myopathy is consistent with statin myopathy, you can either reintroduce a different statin or give a longer acting statin every other day to slowly reintroduce it. Now, just want to make sure that that the audience will not be fearful of statins, because definitely the benefit of statins, especially for diabetes, is far more than the eventual side effects of the drug. And specifically for statin myopathy, if you look at general data, you have to make sure as well that the patient doesn't have um, hypothyroidism. So that's one of the more common comorbidities of statin myopathy and even rhabdomyolysis if you do start high intensity statins in patients who are hypothyroid. So just make sure that, and these patients who are hypothyroid are the ones who are highly dyslipidemic. Okay, so be careful in starting for those. You may start with a low dose or correct the hypothyroidism just to make sure that you do not miss that etiology. And for the elderly, of course, there are no dedicated trial for the elderly, but there's a trial, particularly what you call the treat to target trial, that even for those who are elderly in that subgroup analysis, even those 80 years old and above, there is benefit. But at this time, you still have to do a shared decision making with regards to given especially high dose statins for the elderly who are diabetic, mainly because they are on polypharmacy. Most of these drugs, most of these patients are on multiple drugs, so the drug-drug interaction should be assessed as well. So I again just want to make sure that the audience will not be fearful of starting their statins in our patients. That's it.
Yeah, it shouldn't be because it's very, very rare. In fact, in clinical practice, I think it's more common. What we see is actually perhaps the effect of statin on the liver. I'm not sure about other panelists or other audience have experienced, when ALT is raised more than 3 times normal, do we actually, what do we do? I mean, normally we don't stop, but we change to another statin, which may be more tolerable to the patient. But in my clinical practice, I find that when ALT is actually raised more than 3 times normal, it's actually not the statin which is a culprit. Because when you actually do an ultrasound scan, you found that the patient has got a fatty liver. And it could be the fatty liver, or they call it methyl D now, or methyl D, which is causing the raised liver enzymes. And statin is perhaps not the culprit. So, we have to make a judgment in that way. But nevertheless, it has to be investigated if there is any raise in liver enzymes in patients taking statin. Thank you.
And
Thank you, Professor
also,
Anish.
okay, also the creatine kinase. I mean, for
Yeah.
uh, Dr. Bain said and Professor Anis said, the creatine kinase more than 5 times is, of course, for the elderly an indicator. Instead of SGPT, maybe we say SGPT here in India, that is ALT and ST. Doing, asking the PCP to just keep an alarm on the CK level, doing it if the myopathy is there. But Sam says, of course, Sam says the point.
Yeah. Thank you, our panelists. I would like to summarize that the only absolute guideline based on reason to stop statin completely is the life-threatening reaction. For example, rhabdomyolytic marker CK elevation. Second one, the true statin allergies, as Dr. Share. Just the third one is severe liver injury by using the ALT or IST. Yeah. Thank you, our panelists. I will move to second question. For the secondary prevention, LDL need to reduce greater or equal 50% from baseline to target lower than 1.4. Any exact time or duration to achieve the target? Yeah, I would like to invite, Professor Shakira. Yeah, Professor Dr. Yan J. Matawaran. Can you handle this question first?
Okay, so the question is for secondary prevention. So again, very important that for secondary prevention that we do target a lower LDL. So the question actually identified 1.4 or 55, and there's now an ESC recommendation that for those patients who had multiple episodes of coronary or cardiovascular outcomes within 2 years, that the target can be lower than 70 or 50, or lower than 55 or 1.4. Okay, so when do you so just remember that if you want to reduce the LDL cholesterol by more than 50%, then you expect that 50% reduction with a high intensity statin. Okay, so meaning that's 40 to 80 milligrams of atorvastatin or the equivalent dose of rosuvastatin. So that's 20 to 40 milligrams of rosuvastatin. So that you may actually need combination therapy if your baseline LDL cholesterol it will not be able to be lowered by 50%. So that is why I don't know from the other panelists, but for example, in the Philippines, we now have several multiple fixed dose combination, for example, of a statin, atorvastatin or rosuvastatin together with ezetimibe. Okay, so those are good combinations when your baseline LDL is really very high and you want a more than 50% LDL reduction. So for example, the combination will give you a 56 to 60% reduction in LDL. So I think Professor Anis has mentioned already that in a month or so you can actually see some reduction, okay, in the LDL cholesterol. But what is important is that you do achieve that target. Now there is also a dictum of what you call fire and forget. You basically give the high intensity statin and you really don't need to repeat the LDL as long as there are no side effects of the drug. But I personally would want to repeat it, no, as early as a month or not later than 3 months to make sure that I was able to reach that more than 50% reduction in the LDL cholesterol. But make sure that again for secondary prevention that you do need a higher intensity statin, especially for patients with diabetes. And when you reach that target, again, keep that statin. Okay, so because most patients we tell them, oh, once you reach 55 or once you reach 1.4, uh, uh, oh, okay, I can stop it, no, because I already reached it. So you have to educate the patient that that statin should be kept and your target should be maintained. Okay. Our other speaker, Dr. Marshall's mentioned the danger of actually discontinuing the statin. And there's been a lot of data showing that the longer your patient is on a statin, then there's greater benefit on staying on that statin. So I think that's one obligation that we have to tell our patients that keep it. No, don't just discontinue once you reach the target.
Yeah, yeah, Dr. Bian. I think on top of that, very, very important message there that some patients, once they reach the target, they say, oh, can I like stop now? Because they think statin is a cure, but it's not. It only works for 24 hours. But I think on top of that is also, target LDL of below 1.4 is quite low. And I'm not sure, even among my patients, how many actually is able to reach that target. So we have to address the problems of medication adherence on top of it, as well as lifestyle modification, because we know that LDL laden food is very, very common in Asian population. Saturated fat is normally the culprit. So we have to address their intake on saturated fat, because most of my patients, for example, they think that once they're taking a statin, that it gives them a license to be taking steak every day, for example. So no statin in the world will work if we continue to do that. So I think that's an important message as well, that we have to address the saturated fat problem contributing to the high LDL level in our population. Thank you.
Yeah, thank you. Yeah, I would like
I will
to.
just add some more, Professor
Yeah,
Ben. Yeah, the problem with the cholesterol level is actually we need to address our patient. It's not only LDL we need to worry about. There's another beyond LDL we need to introduce to our patient. Newer examination like non-HDL, like triglyceride-rich lipoprotein or either kilomicron, which can also have an additional risk for cardiovascular risk. Actually, regarding the LDL, if we have those laboratory examination in our country, we need to check to ensure the risks are not there. But another thing important is more than other than either drug, either diet, we need to address our patient to maintain their body weight. We know if our patient is obese, if they lower their body weight by 7%, this also help to reduce their cholesterol level. Maybe that's for me. Thank you.
yeah, thank you. I would like to ask the opinion from Professor Dr. Sharifa. Could you share your experience?
Sorry, to share my screen?
Yeah. You can just share your experience or you take some comment. Yeah.
Okay, hang on. Mm,
Yeah.
this one.
Yeah. Number two, the second dairy prevention LDL need to reduce. Yeah. Raise or equal 50% from baseline to target under 1.4. any exact time or duration to achieve the target? Yeah, thank you.
Okay, so according to the Singapore guidelines, we don't have a specific duration or treatment that we specifically specify to reach this LDL target of 1.4. But from what I know from my friends who are cardiologists, they actually mentioned that if you can reach 1.4 as reach your LDL target, whether it's 1.8, 1.4, as early as possible, that would be best, because studies have shown that the longer your LDL stays low and remains very low, the better it is for you. So usually that's what I tell my patients. But it has to be a shared decision making, because like Prof. Anis mentioned as well, 1.4 is quite very difficult to achieve in some patients. So I completely agree with that, and I echo that sentiment as well. So sometimes even to reach 2.6 for some patients as well is they would say it's very unreasonable. So what more 1.4? So it has to be a balance. We have to inform the patients as well, and then we discuss together. But we also have to take into account when we increase medicines, or when we add statin therapy, or even ezetimibe or PCSK9 inhibitors, other agents to lower cholesterol, that the patient is actually able to tolerate. So the important thing is they are able to tolerate at the best highest dose that will actually achieve the LDL target.
Yeah, thank you, Dr. Sharifah.
Welcome.
Yeah, I would like to move the relevant question. Which is the best tool can be used to risk stratify patient who is younger age group, who is already hypertensive with diabetes? Yeah. So one more time, I would like to invite Professor Sharifa handle this one first, and after that, our panelists will share the experience for each country. Thank you.
Thank you. So for my patients, I would actually still use the local risk calculator that we have in Singapore. So depending, so they have hypertension, they have diabetes. I cannot use the Framingham risk score in Singapore, because that does not take into account diabetes for patients. So I would use the score that I actually gave in the slide earlier about the risk calculator that we have. So that one takes into account whether patients are on antihypertensives. So it's not just whether they have hypertension, but whether they are on medicines for it, and also if they have diabetes. So it takes into account these risk factors, and then from there we can risk stratify accordingly. Yeah. If any of the panelists or other doctors would like to add, please do.
Yeah, thank you. How about the experience from India or Philippines or Malaysia? Yeah, please share. Thank you.
If I may share, Prof, for Malaysia.
Yeah.
Yeah. In Malaysia, if the patient has got diabetes, we do not need to calculate their risk score already. They automatically goes to high risk. And if they have additional risk factor, or they have had complications like CVD complications, any of the CVD complications, then they go to very high risk. Because the Framingham risk score in Malaysia is been validated in primary care, and the way it's categorized actually it's into 4 categories, not the 3 categories as per the original author, Di Agostino, 2008. So the way we categorize is actually low risk, intermediate risk, high risk, and very high risk. So if you have diabetes and it goes to orange, I normally use the traffic light system when I educate my patients regarding their risk stratification. So from green, yellow, orange, and red. So if you have diabetes, then it straight away goes into orange, which is high risk. And we treat them as high risk, and the target is all for high risk individuals. So that saves time really for doctors. You know that you have diabetes patient is high risk. That's the way we practice in Malaysia. Thank you.
Yeah, thank you.
For India,
Yeah.
if we now have a data that we have 212 million people who have diabetes. I mean, if you take the HbA1c and the fasting both together, so that's the Lancet paper, which has remarkably stunned the whole world. We are more than 1 out of 4 people in the world living, the Indian diaspora, we have diabetes. So as Professor Anis said, being an Indian, by virtue of being an Indian, you are at high risk. So you're in orange. But we have something called, we have an organization which is called the Lipid Association of India. And they found out that by that was I think 2 years back, they said that we'll have risk factors and markers. So the major ASCVD risk factors is age below 45 for males, and age above 45 for males and 55 for women. We are actually now trying to, we as diabetologists, like I'm an NCD specialist. My organization is Meta. We are trying to promote school health, and we are trying to nip all the problems in the bud. I would make a very controversial statement, if you allow. The whole world, I mean, World Health Organization, and I see Dr. Bain already smiling. We are talking about premature reduction of mortality. This what is this premature mortality? 30 to 69 years is the NCD time that World Health is talking loud about. Now, if that is so, then by 30, everyone has some risk factor, major risk factor already. So how can reduce the mortality there? So why not do a school intervention where the age of birth 12, maximum till 16? So that's what we do. That's our target. And I believe all my brothers from our South Asian population are also feeling and maybe doing the same. So it's not 45 or 55, maybe it is before 16 that we should target. But when it comes to the atherosclerotic CVT risk factor, of course, a certain age above 30 should be considered. Cigarette smoking, in our clinic, we should have a Fagerstrom score. We should talk about cigarette smoking. High blood pressure is already the case, as Sir mentioned. We also need to focus on the low HDL part, and that is because LDL, we don't see the small dens or the buoyant. So it's 100, maybe it's 70, but they're small dens, they're atherogenic, very pro-atherogenic. So looking at these, because we are somewhere at the end of the day, we are a big country, 1.46 million officially, but we're a very poor country. For mostly more than 1.2 billion, at least they cannot think about 2 square meals a day. Now, premature history of this, family history. Whether a parent, any of your parents or your, first degree, like maternal uncle, passed away before 50. Auntie passed away before 55. Your CKD stage, as Dr. Marshall, I think he was talking about the other points like ApoB and HCT. They're out of question for a general population. So uh, uh, maybe one risk factor which is significantly elevated. Uh, and the remembering the 5 components of metabolic syndrome. Please don't forget to do the waist circumference, waist height ratio, etc. Will automatically come in the calculator. And as ma'am said, Professor Anis said, today we must be very cautious about the MASLT. We must have a FIP4 score done for everyone. I mean, we're doing it at it doesn't apply to less than 35 years of age. That's a kind of a caveat we have. But maybe, if required, the SGPTA gives you or a simple ultrasound, if you care to do, because of the whole lifestyle changes. It is entirely ultra processed food, saturated fat, microplastics, and too much of stress. All putting in, mental health and liberties. And we must not forget, once we are talking about management of cardiorenal complications in diabetes, diabetes is the outcome of extra fat in the liver, in the wrong side, not in the adipocyte. So how do we, make these areas identified as a primary care physician? What is my job? Whom to target from the family history, from my clinical examination, from my laboratory data, and then maybe indigenously design my own low risk, moderate risk, as ma'am said, traffic lights. You are a person, Indian, you have diabetes, you have hypertension, you are already at high risk. So, please start a statin, whether you're, and of course, today we ADA talks about 40. Why not between all of us, we make it 30? 30 and think about ASCVD. We can think about a statin early. Why not? I mean, because we have seen statin doing reduction not only in LDL but mortality. in people with diabetes more than people without diabetes. I mean, that old study, what was that study? I forgot. I mean, the first 4S, the simvastatin study. We unfortunately don't have simvastatin. We don't use here in India, but you people do. So that 4S clearly told us categorically 42% reduction of mortality for people with diabetes and 32, a big difference.
Yeah, thank you. Yeah, for the in the Vietnamese point of view, Dr. Tuan and I, we agree with you. But for younger adults who already have hypertension and type 2 diabetes, the most traditional, the 10-year CVD calculator, for example, from Inham, they tend to underestimate risk because the first one, the age is the strongest driver in their equations. The lower of age is underestimate. And the second one, diabetes and hypertension, they confer on the high lifetime risk. Even when short-term 10-year, the risk, they look low. So we tend to think about the QRISK-3 from UK. Yes, because they can use valid from the age of 25 and incorporate the diabetes, hypertension treatment, CKD, family history, for example, that's helpful for younger adults. Yeah, I would like to thank you for all the panelists. I want to move the second one. The next question. What is the most preferred investigation to be performed to detect early involvement of the kidney in a patient of diabetes mellitus? I would like to invite Dr. Tuan in Vietnam to handle for this one first, and after that, the panelists can share. Yeah, thank you.
Thank you, Professor. And what is most preferred investigation to perform to detect early of the kidney and in the patient of diabetes? As I show on my slide is on the patient with diabetes, especially newer diagnosed diabetes patient come to see us frequently, at least one times per year. We have to do the test to screen the kidney function. As I showed on my slide, we do the estimated glomerular filtration rate at least one time. It depends on new diagnosed patients or have a long time diabetes. The second, albumin, urine albumin presence on in the urine albumin or not. We do the urine albumin to creatinine ratio together with EGFR one times a year. It depends on the how much the fasting glucose level. If the patient have hypertension and a very high fasting glucose level, and we can make more one maybe at 6 months, every 6 months, and even if your patient has diabetes more than 10 years, we do it 4 times a year. Every time we use only 2 tests, is EGFR and URCI only, no more, because we are primary care physician. It's acceptable for us to do the test in the primary care.
Yeah, thank you, Dr. Tuan. I would like to add a little bit in Vietnam, some rural area or small income health center, we don't have a UACR. So we can use the dipstick to test the protein. That one important evidence for the leakage or the damage from the kidney.
Yeah, I agree with you. I agree with you, Professor. The test developed by AstraZeneca company, we can use the dipstick for detection only protein, not albumin, and it's maybe false results, but it's a for screening is acceptable.
Yeah, thank you. I don't know. Yeah, I would like to invite Professor Anis. Yeah, can you share your experience with us? Yeah.
Sorry, Prof. Can you repeat the question again? I was just looking at the questions that they answered.
Yeah,
Which
what
one?
is number 4? What is the most preferred investigation to perform to detect early involvement of kidney in patient diabetes mellitus?
All right. Okay, that one. Yeah, I've actually answered it in writing as well. In our clinical practice in Malaysia, I am from a university primary care setting. So we have the access to do the UACR, the urine albumin creatinine ratio. So I think this is should be recommended if you have the resources to do it, because you actually can detect, the microalbumin with the creatinine ratio. So there is a range, lab range already recommended for us. I think it's different for male and female. If I'm not mistaken, about 2.4 for male or 3.5 for female, something like that. But if you, so I think that's the best to in primary care. If you have the resources. But unfortunately, many of our primary care clinics with less resources, they may not have access to even UACR. Then you can actually do the standard UFVME to check for proteinuria. Of course, it'll be late already once you detect proteinuria, because microalbumin is supposed to appear earlier in the very, very early stage of kidney damage. So perhaps the other professors can tell us, if you detect microalbuminuria or UACR raise today, how many years it takes for the patient to go into the end-stage renal failure. Because there are evidence showing this if you don't do anything once we detect it. And of course, I think from proteinuria, if you detect proteinuria, if you don't do anything, then, perhaps patient would develop end-stage renal failure in about 5 to 10 years time without any intervention. So that will be my response for what we do in Malaysia. Thank you.
Oh, if you allow me, very well said. I mean, absolutely, Professor Anis.
Yeah, thank
But
you.
while she was speaking, I was listening to a wonderful professor. The first clinical sign suggestive of diabetic kidney disease is the initial glomerular hyperfiltration, and that occurs in around 50% of people type 2 and more in type 1. So, due to that increased, intraglomerular pressure, the elevation of the GFR, which is maybe more than 120, per minute per 1.73 square meters and all that. Hyperfiltration is followed by the pressure effect, leaking the albumin out. So these patients, I mean, when you see in type 1, we say the USAR is normally less than 3.4 milligram per millimole. Now, during the first 5 years. So we say we don't coax them to go in for all the tests like we do for a type 2 diabetes. At the diagnosis, you do the battery. For type 1, we wait. You're right. But in subsequent 10 to 5 years, albuminuria develops in some patients, and that is there we have genetic components as well, and they progressively, go down the ladder if no intervention is taken. Now, once USCR is above 34 milligram per millimole, the GFR now starts progressively declining at a variable rate. Now, all these studies, Credence trial, all these gliflozin trial, they completely showed us that how effective they are in arresting the EGFR fall. So about 50%, finally, we have agreed now that 50% of the people with more than USCR 34 will progress to ESRD over a period of 10 years and approximately 75% in 20 years. So Madam Anis was saying, that 5 years will not be that bad, maybe 10, 20. So let us feel good about it. But the point is, we cannot delay and sit tight on it. We have to act and intervene early. Because in terms of renal excretory function, GFR is of course considered to be the overall best, but that process of doing the 24 hours we don't do. We have now MDRD and all that calculation, and it varies. The male, female, ethnicity, etc. Whatever the National Kidney Foundation is saying, I think we have to go by that. We have to stick to those principles and go ahead gradually. But USCR is something that we should not miss as PCPs.
Yeah, Professor. So I do agree. So the quickest test that can be used
Yeah.
is, for example, is of course the EGFR using your creatinine. You compute the EGFR and of course the UACR. So just make sure that there's caveat in the interpretation primarily of the UACR. So ideally, you have to have a benign, clear urine to actually interpret the UACR accurately, because if you have urinary tract infection, you have pyuria, then that will give you a falsely elevated UACR. Okay, so again, Professor Dr. Debashis has mentioned about hyperfiltration, and when do you suspect it? If, for example, your patient has, instead of a high creatinine, your creatinine is actually low. It means that your kidneys are working extra hard. So that's why you have that creatinine. And mostly these are patients already in the hyperfiltration range. And we all know as well that the usual course of diabetic kidney disease is progressive proteinuria with progressive reduction in the EGFR. But be careful again, because there is now what we call non-proteinuric diabetic
Yeah.
diabetic kidney disease. Because of the wide use of RAS blockers, your ACE inhibitors and your ARBs, that some patients may actually not present with that much proteinuria, but still DKD. So there are some exceptions to the rule, but very important that, again, I think it's very consistent for all of the speakers who mentioned earlier, that at least do a UACR and your EGFR use computation, your creatinine. How often do you do it? If you're familiar with the KDIGO heat map, now there's depending on the risk or the color in the heat map, that's where you will be advised as to when to refer to a nephrologist. How often do you repeat the UACR, or how often do you repeat the EGFR calculation with creatinine? So again, there's some guidance to it. There may be some, uh, you know, um, uh, outliers, but in general, that's how we do it.
And what a way to say that. You reminded me of that non-albuminuric renal impairment. Fantastic. So that is where we teach our students. Make sure kidney problem is a microangiopathy, but when it is non-albuminuric renal impairment without a RAS blocker, then think about a macroangiopathy as the renal pathology. So in glomerular dysfunction is actually not the issue here. It is the tubulointerstitial and the vascular problem. That is the histological change we see in DKD. So
Yeah. If I may ask the other panelists and speakers, in your setting, how many of you have the EGFR calculated automatically by the lab?
Yeah.
You do, yeah, yeah. So it's easier, I think that's the key really. Most labs in Malaysia now, they actually auto-calculated the EGFR when we request the renal profile. And they even, put there the stages of CKD already according to the EGFR range. So I think that's very, very helpful for our clinicians to decide which, rather than, trying to find an online calculator, trying to calculate the EGFR.
and also the patients. Don't forget, the patients, when they see the report, their alarms are raised. What is this? What is this?
Very
G3
true.
and AF3, what does it mean? So, and kidney wise, people are very afraid when they hear the word kidney. Liver, they don't mind. But kidney, they do really mind. Brain also, they don't mind.
Yeah, I
Yes, they
think
do.
yeah,
Yeah.
that they do. Yeah, I think very useful for us. We remind all of our participants that at the primary care, when the diabetic patient visit us, we have to think about the first presentation from Professor Sharifa about CVD risk calculator. Beside this, we can think about the estimate CKD risk factor. That's a new one in both in one. You see, osmos, we think about glucose control first in the past time, but now in the digital area and with the advantage of the lab, we can move one step. That's the treatable threat for the CKD in diabetes for a long time. Yeah, I would like to move the next question for Dr. Tuan. Yeah. After SGLT2 initiation, do we need to withhold the drug if it's caused a drop in the eGFR? After considering other causes, any significant value of percent of drop in what numbers? Yeah, thank you.
We cannot hear you, Dr. Tuan. I think your mic is off.
Yes, the question here is when we started, when we start using SGLT2 inhibitor, the kidney function usually a little bit come down. It's only functional. Don't worry about this. It's only 2 weeks maximum. Only 4 weeks.
4 weeks.
4 weeks maximum, and on the kidney function a little bit gradually come back, and bigger compared to using placebo. I think here another medications. And so we don't we have to advise the patient, don't worry about this. It's only functional. In 2 weeks, 4 weeks, everything will be okay to compare to not using the SGLT2 inhibitor. Is in my practice, I never give the patient doing the test during 4 weeks. Only after 4 weeks, if your patient wants to check their kidney function, and then we advise to do the test. Before 4 weeks, never, because the patient afraid of the why I use this medication, but my kidney function come down, and so my advice is we can continue using this medication, but doing a test only after 4 weeks.
And one more thing is that if there's a significant decline, when you do it and see it's more than 30% or anyway, that more than 30, I remember. So 30, or it should be more than 30% that you have to, think about it. I mean, ideally, that initial dip, we know it is because of the efferent arterial constriction, and that is the mechanism of the tubuloglomerular feedback control. So we want that to happen, and we now know that you can go even beyond 20 your EGFR. If it falls even at 20, still you can continue until you think of an RRT. So that way it is a kidney safe drug at the initial point of contact. So it's that we should not be warranted to stop an SGLT2 inhibitor for kidney reason.
Yeah, thank you, Dr. Professor Bien. Now it's time limited of time. I would like to summarize it today. We would like to hear 3 in the primary care. You see, in 1 minute, we can practice change most in primary care. Yeah. We heard from Dr. Professor Sharifah, cardiovascular risk stratification, and from Dr. Tuan, CKD early screening. And now we have 3, I think we have at least 3 actionable pearls. The first, we have to early combine risk assessment with sequential care in primary care. Both of them combine one. With the in family medicine, we can use the IC, idea, concern, and expectation, and a biopsychosocial model to set up priority times. The second one, UICR and EGFR are a critical as HbA1c in glucose control. The third one, GLT2 and GLP1, they are dual benefit therapy when available. That's very important. We can include this approach in cardiovascular stratification, early schedule screening in regional research, and also in training topic for our region in all the Southeast Asia. Thank you very much to all our speakers, panelists, and participants across the region for joining us today. This concludes the region parts of our program. Participants outside Vietnam maybe now exit the webinar. And for Vietnam, only segment, greeting our collector in Vietnam. The following part of the program will be presented in Vietnamese to fulfill continuous medical education requirement. We now explore the Kermi program, supporting family physician in management type 2 diabetes patient in Vietnam. Yeah, you can look at the video. Yeah. After you watching the Kermi presentation, please complete the post-webinar quiz to receive your CME point. On behalf of the organization committee, I extend my sincere appreciation to all the participants. We look forward to welcoming you to our upcoming CME program. Yeah, and say goodbye to our panelists, and I hope that we have a so wonderful and interesting exchange, share experience among the region. We'd like to say thank you and hope that we can have another meeting in close future. Thank you, our panelists. Yeah. Thank you, our speaker. Yeah.
Thank you very much, Chairperson, Prof. Pan, and all the panelists, and also all the audience. Thank you.
Thank you, Professor Anis. Yeah. Yeah, thank you, all of you. Yeah.
We have made a big family. We should stay connected and have this more and more.
Yes.
Exactly, sir. We can do research and training together. Thank you. Bingo.
We should indeed. Thank you, everyone. Thanks.
Yeah, thank you, everyone. Yeah.
Bye, everyone.
Với bài báo cáo là tầm soát yếu tố nguy cơ tim mạch thận cho bệnh nhân chăm sóc ban đầu, ứng dụng chương trình Kermi. Xin mời thầy An này.
Thưa quý vị đại biểu, thì chúng ta sẽ thấy Ở đây gánh nặng của tim mạch thận thì mọi người đều biết hết, đúng không ạ? Rất là nhiều. Tim mạch thì tử vong, thận thì bệnh thận mạng, đúng không ạ? Đây mọi người đều thấy cái câu chuyện đó ở đây. Rồi, thì bên cạnh đó, cái điều quan trọng là nó dự báo được. Mọi người đều biết, bệnh nhân có đái tháo đường, tăng huyết áp thì sẽ dự báo được. Và quan trọng là nó được nhận biết từ các yếu tố nguy cơ. Và cơ chế chung của nó là viêm, hoặc là stress, oxy hóa, hoặc là cơ học. Và dần dần nó đi tới tổn thương cơ quan. Thì cái con đường này, thầy cô các anh chị thấy trước đây là một cái giả định, nhưng hiện nay lát nữa sẽ thấy có bài báo chứng minh nó là thật, nó là hội chứng Karemi đàng hoàng, hoặc là bệnh Karemi ha. Rồi, thì vấn đề lớn ở chúng ta bây giờ không phải chỉ có một nguy cơ, người bệnh vừa có đái tháo đường, vừa có cao huyết áp, đúng không ạ? Vừa có bệnh lý nền khác, thì bây giờ càng nhiều nguy cơ thì các anh chị thấy sao? Thì các cái kết cuộc càng dễ xảy ra. Ví dụ như càng nhiều nguy cơ đái tháo đường, rối loạn lipid, thì nguy cơ nhồi máu cơ tim sao ạ? Nhiều hơn. Hoặc là bên này sẽ đột quỵ nhiều hơn, có thể tăng gấp 5 lần. Và như vậy các chuyên khoa ngày nay, các anh chị, nếu anh chị nhìn, các anh chị thấy các chuyên khoa ngày nay nó thay đổi mục tiêu theo từng giai đoạn, đúng không ạ? Trước đây thì giai đoạn sớm, giai đoạn muộn, rồi giai đoạn biến chứng, đúng không ạ? Thì trước đây là cải thiện chất lượng cuộc sống, ngừa diễn tiến nặng. Nhưng bây giờ thì nó đẩy tới sớm hơn. Cái bánh xe này chúng ta thấy nếu nó quay ngược lại nữa thì nó sẽ ngăn được cái dưới này. Thì như vậy sẽ có gì ạ? Tầm soát định kỳ, phòng ngừa, hoặc là quản lý nghiêm ngặt, đúng không ạ? Thì như vậy rõ ràng chúng ta thấy bệnh tim mạch và đái tháo đường là những cái gánh nặng nãy giờ chúng ta đã bàn rất là nhiều rồi. Và bây giờ chúng ta thấy tư duy theo cái quan hệ nhân quả đó thì nó có thật. Bệnh lý tim mạch, đúng không ạ? Đây, nó không xuất hiện mà nó là âm thầm qua những cái mà chúng ta đều biết hết. Nhưng ai là người sẽ nhận ra nó? Ai là người sẽ điều trị sớm? Các anh chị thấy phần lớn bệnh nhân những nước chậm phát triển, những nước đang phát triển như mình thì đều chờ tới gì ạ? Tới cuối hệ lụy người ta mới đi khám. Thì khi đó biến chứng đã xảy ra rồi. Như vậy khi người ta mới tới thì ai là người đón đầu trong chăm sóc ban đầu? Chính là chúng ta, đúng không ạ? Và như vậy thì mọi người đều thấy rõ có quan hệ nhân quả giữa những yếu tố nguy cơ và kết cuộc. Và như vậy một cái phản biện chúng ta nói rằng thì rõ ràng đợi tới biến chứng, đợi tới chạy thận, đợi tới thì nó chậm quá rồi, làm sao cản được nó? Thì người ta thấy rõ ràng là thầy cô các anh chị thấy hiện nay cái tầm soát vẫn được ưu tiên hơn. Và mọi người hỏi thì tầm soát bây giờ phần lớn các gánh tầm soát người ta lại đổ cho các thầy cô ở chuyên khoa sâu. Nhưng các bạn nhìn thấy phòng khám nội tiết vắng bệnh không? Có vắng bệnh không? Không, rất là đông. Thì các thầy cô đó có rảnh đi tầm soát không? Không có thời gian rồi các anh chị. Thì cái gánh nặng đó là giao cho chúng ta là các bác sĩ tuyến đầu và bác sĩ gia đình. Và xu hướng mới thì đây, cái mà hồi nãy tôi vừa nói là treatable threat. Đây là cái xu hướng mà nó đẩy lên một cái nghiên cứu thời sự từ các thầy bên hô hấp đã đưa ra. Và bây giờ cái nghiên cứu là randomized clinical trial, không còn là cổ điển nữa, mà bây giờ nó đẩy qua là randomized clinical trial mà platform, tức là động hơn. Từ RCT người ta chuyển sang nghiên cứu đời thực, tức là real world. Thì bây giờ nó là sang cái treatable threat ha. Và như vậy thì những cái người mà có cái nét Thí dụ như bên COPD ở đây thì có thấy đây là cái slide tôi mượn của thầy Vinh ha. Thì những cái nét điều trị được thì nó bao gồm gì hành vi, môi trường, biomarker, triệu chứng tại phổi, triệu chứng ngoài phổi. Thì người ta dựa vào đây để người ta tiên đoán nếu cái gì bệnh nhân có cái nét này thì người ta đáp ứng với thuốc gì. Do đó nếu người ta chẩn đoán sớm, điều trị sớm thì hy vọng cái biến chứng không có xảy ra. Và càng nhiều nguy cơ thì càng dễ bị cái kết cục chúng ta đều biết rồi. Và phát hiện sớm cái nguy cơ mạch thì nó sẽ phòng ngừa được biến chứng. Thì mọi người ai cũng biết cái câu chuyện này hết. Tôi đi nhanh qua. Bởi vậy đối tượng tầm soát chúng ta là gì? Là những người trưởng thành, đúng không ạ? Từ 40 tới 75 tuổi, vẻ ngoài khỏe mạnh, hoặc là người trên 75 tuổi, hoặc là bất kỳ bệnh, cái người nào có những cái tình trạng, thí dụ như đây thì có các anh chị có trên bảng hết ha, thì tôi cũng không đi sâu. Đặc biệt là nhấn mạnh tới và những cái đái tháo đường, hút thuốc lá, những cái nguy cơ béo phì, rối loạn cương, cái này cũng vui lắm ha. Rồi, và như vậy nguy cơ càng cao thì càng phải can thiệp càng tích cực. Thì ở đây các anh chị thấy chúng ta thấy càng đánh giá tốt, càng đánh giá sớm nguy cơ tim mạch thận thì nó càng dễ kiểm soát. Và như vậy cái điều quan trọng là làm sao để chúng ta thấy nhiều nguy cơ được tích hợp lại cho nó dễ cho chúng ta sử dụng. Thì như vậy người ta đã nghiên cứu, các thầy cô bộ môn tim mạch người ta đã bắt đầu người ta đưa tới những cái nghiên cứu. Thì chúng ta thấy những cái chứng cứ cho thấy rằng các bác sĩ chưa có quan tâm lắm về các cái biến chứng này, ngay cả dù chúng ta được kỳ vọng là sẽ làm. Nhưng thực tế những cái bài báo nghiên cứu cho thấy rằng cái nguy cơ tim mạch này nó chỉ có được ước lượng là chỉ có 34,4% và chỉ có 55,7% ước lượng đúng thôi. Và các anh chị thấy ở trạm y tế bây giờ mình làm gì? Các thầy cô anh chị bây giờ mình được có tuyến đầu, mình ở trạm y tế. Anh chị thấy người ta có muốn tới trạm y tế gặp mình không? Không. Gặp chị, đúng không ạ? Không có lý do gì để gặp hết. Nhưng nếu người ta tới chỗ đó, mình đặt cái POD, tức là Point of Diagnostic, tức là cái chẩn đoán tự động đo huyết áp, đúng không ạ? Cân nặng, có cái cân gym á, báo được mỡ trong cơ thể của mình. Ví dụ nhìn tôi nói cái bụng thầy bự quá, xúc phạm hình thể, thiệt. Nhưng mà nếu bước lên cân, đúng không ạ, thấy mỡ nội tạng tăng thì sao? Sợ đó. Và tôi sẽ hỏi tiếp, ủa bây giờ sao? Thì vô thử máu đi, đúng không ạ? Mà nếu thử thấy rối loạn lipid thì sao? Bắt đầu thuộc nhóm gì để chúng ta nói chuyện với họ. Chứ bây giờ nhóm mình đang ngồi ở đây, thầy cô mời vô để ngồi gặp thầy Toàn thì tôi nghĩ không ai gặp hết chắc chắn luôn, đúng không ạ? Tại tôi đâu có chuyện gì phải nói đâu, trừ khi tôi có gì có bệnh. Chính những điều này thầy cô thấy là tại sao các trạm y tế của mình, các bác sĩ được đào tạo ra rất tốt nhưng vẫn không thu hút được người bệnh. Là vì cái người ta cần các anh chị không cung cấp. Người ta cần cái này nè, người ta cần biết đó, như thầy cô các anh chị thấy không? Người ta không biết được người ta có nguy cơ, và ngay các bác sĩ cũng không tính đúng được đó. Và bệnh nhân có nguy cơ cao hơn 85% đánh giá thấp, và bác sĩ lại đánh giá thấp nguy cơ bệnh nhân có nguy cơ cao. Thì những con số này biết nói lên là gì? Ngay cả chúng ta là người được trao cái trọng trách, chúng ta vẫn chưa làm tròn trách vụ của mình. Tức là chúng ta chưa quan tâm, chưa học. Tiếp theo đó thì các anh chị thấy không? Đây. Thì như vậy cần có một cái chiến lược tốt hơn để đảm bảo các bác sĩ gia đình ghi nhận các yếu tố nguy cơ cần thiết. Thì ở đâu ra? Đó là hồ sơ sức khỏe học gia đình. Đó là công cụ các anh chị đã có. Sẽ có cái chất lượng. Các bác sĩ chăm sóc ban đầu ở vùng nông thôn của Úc thì cho thấy rằng họ càng sử dụng nhiều các hệ thống bệnh án thì cho thấy cái việc cần cải thiện cái việc ghi nhận này online, tức là trong thế hệ kỹ thuật số hiện nay ha, để cho các anh chị thấy. Và như vậy y học gia đình của mình thì cái hình này các chị đời cổ đó thì chắc chưa biết, các anh chị đời mới thì quen lắm rồi, đúng không ạ? Tại chức năng của đây như hồi nãy nói, bác sĩ gia đình là chăm sóc và quản lý, tức là xác định nguy cơ người bệnh vào thì phải biết người này có cấp cứu hay không, có bình thường gặp bệnh đồng mắt, bệnh bỏ sót, và người khỏe thì đây. Và chúng ta sẽ xử lý dựa trên cái mô hình tâm sinh xã hội và ICE để lựa chọn cái ưu tiên, kế hoạch can thiệp, dùng thuốc và không dùng thuốc, để nhằm tới cái tạo lòng tin, tăng tuân thủ. Đây thì cô anh chị thấy ha, với hồ sơ sức khỏe đó. Thì những cái này, những cái mà cập nhật mà các anh chị xưa đó, các anh chị có tuổi mà học những cái lớp trước đó thì hầu như là chưa biết ha. Rồi, và giá trị cốt lõi của chuyên ngành thì cũng nhắc lại với các anh chị. Thì giá trị cốt lõi của chuyên ngành là xác định ưu tiên, và chỉ định gồm có dùng thuốc và không dùng thuốc. Thì cái trạm y tế hiện nay các anh chị nghe nói là làm theo 6 nguyên lý học gia đình đó, thì thực chất là làm cái hồ sơ sức khỏe học gia đình. Tại trong này nó có 6 nguyên lý trong đó, chứ không có gì lạ đó. Vì vào thời điểm đó chúng ta chưa đủ bác sĩ ở trạm y tế, chưa đủ bác sĩ gia đình đó, và trong đây nó có cả công cụ và cả mô hình. Và bác sĩ gia đình thực hành cái kỹ năng lắng nghe tích cực, chủ động, và có nhiều cái kỹ năng hoàn toàn khác. Do đó các anh chị thấy chuyên ngành học gia đình là có gì ạ? Chuyên khoa 1, chuyên khoa 2, thạc sĩ, nội trú, hoàn toàn khác chứ không có giống đâu các anh chị. Và như vậy thì trong cái việc yếu tố nguy cơ tim mạch thận thì bác sĩ đình sẽ giáo dục, tư vấn, thay đổi lối sống, quản lý theo dõi, phối hợp liên ngành. Đó là cái chức năng của bác sĩ gia đình. Và bên cạnh đó thì nãy giờ các anh chị cũng thắc mắc là có chứng cứ không? Chúng ta nói về tư duy phản biện, tư duy sáng tạo thì có chứng cứ. Nãy giờ các anh chị thấy ngay các bác sĩ Mai Phương cũng đưa ra theo cái định hướng mà tôi vừa nói. Với bác sĩ gia đình là chúng ta bây giờ phải có tư duy phản biện, tức là nói ra phải có gì ạ? Chứng cứ, chứ không phải ai nói gì nghe đó. Thì ở đây thì có những cái nghiên cứu đầu tay là đánh giá nguy cơ tim mạch thận. Thì các anh chị thấy đã có, và rõ ràng thì cái số thấp và trung bình ở đối tượng tới khám là người khỏe mạnh thì bắt đầu có đó, tức là 57,3%. Thì chỉ còn một số ít thôi là cao và rất cao, tức là số này là số tiềm ẩn. Thì cái số này cũng là cái số mà chúng ta đang phải tập trung vô, vì nó có và có thật. Chỉ có cái chúng ta không đánh giá thôi, đúng không ạ? Chúng ta bỏ qua. Và chính cái sự tiến triển dần của nó thì đừng thắc mắc tại sao khi người ta tới với chúng ta, tới bác sĩ nội tiết thì chuyện nó đã rồi. Và tương tự thì đây là các yếu tố nguy cơ thường gặp trong cái nghiên cứu này. Và như vậy ở đây là một cái diễn tiến thì cô các anh chị thấy rất là rõ ha. Từ không có nguy cơ, bắt đầu có rối loạn mô mỡ, rối loạn chuyển hóa, rồi bắt đầu câu chuyện diễn ra, kể cả đột quỵ, kể cả biến chứng tim thận. Và như tôi nói thì ở đây người ta đặt ra câu chuyện là Karemi là cái từ viết tắt, nhưng thực sự đây là cái hội chứng tim mạch thận có thật hay không. Thì người ta chứng minh được là cái hội chứng này là có thật, nó có cơ chế sinh lý bệnh rõ ràng. Nhưng vấn đề hiện nay người ta đang đặt ra là nó là hội chứng hay là bệnh. Thì có hai cái bài báo. Thì các anh chị thấy một cái nơi thì gọi là bệnh, disease of Karemi ha, là tam chứng ha. Thì ở đây nó có sinh lý bệnh rất là rõ, tập trung vào viêm như hồi nãy giờ chúng ta nói ha. Thì như vậy cái quy trình này nó đã có chứng cứ, đã có nhân quả rất là rõ. Hay nói nôm na là có nhân thì cắt nhân thì có thấy quả không? Hiếm. Chính điều đó là cái điều chúng ta mạnh dạn để chúng ta thực hành, chứ không phải chúng ta chỉ gọi là nhắm mắt để đi làm. Và như vậy ở đây chúng ta có cái xu hướng chuyển đổi số. Hiện nay chúng ta thấy có các anh chị thấy chúng ta nói rất nhiều về chuyển đổi số. Thì chuyển đổi số nó ba cái là: thứ nhất là số hóa dữ liệu, số hóa quy trình và ứng dụng đó vào trong thực tế. Thì hiện nay chúng ta thấy ở đây chúng ta thấy có cái hồ sơ sức khỏe học gia đình. Thì chính đây là cái mà chúng ta đang có, cũng có hồ sơ điện tử rồi. Thì chúng ta đã có từ năm 2007 tới giờ. Thì mong là các anh chị đang thực hành và sẽ tiếp tục thực hiện cái đó với lồng ghép rối loạn giấc ngủ nè, lồng ghép bằng chân tiểu đường nè, lồng ghép các cái chuyên khoa khác vào. Thì chúng ta là cái người sẽ giúp cho bệnh nhân đánh giá, theo dõi, kiểm soát. Và phần nào họ nhận được nguy cơ sớm thì họ sẽ gì tuân thủ sớm. Và ở đây thì các anh chị nhìn xem, thì chúng ta có hai loại. Thứ nhất là chúng ta có hồ sơ sức khỏe học gia đình, tức là ESR. Nó không phải là EMR. ESR tại sao có chữ H? Là vì chúng ta quản lý người khỏe lẫn người bệnh, hai giai đoạn. Còn bên này tức là một bệnh viện, người ta có nhiều bệnh nhân thì người ta có ESR. Còn bên đây một bệnh nhân đi nhiều bệnh viện thì người ta có PSR, tức là Personal Health Record. Thì ở đây cái sơ đồ chúng tôi đang thấy là hiện nay ở đây là cái trang thiết bị hồi nãy tôi mới nhắc với các anh chị, đó là cái POD, tức là cái Point of Diagnostic. Thì nửa tầm soát giấc ngủ, hoặc là ở đây là cái cân gym á, tức là đưa lên đây thì nó sẽ cho các mười mấy cái thông số in body. Và ở đây là đo huyết áp, cân nặng tự động. Thì cái này nó đã có ở các trạm rồi ha, đã thí điểm. Và ở đây là tự động hóa hết để tránh hiện tượng áo tròn trắng. Và trong dịch bệnh thì người bệnh chỉ tới đây tự khai báo, kể cả giấc ngủ. Và những thông tin này nó sẽ chuyển vào trong ESR. Cái này đã lồng ghép vào bệnh án điện tử của chúng ta. Và như vậy thì chúng ta sẽ có một cái gọi là Smart Office, tức là cái trạm y tế thông minh. Từ những điểm này đưa đến chúng ta có thể bắt đầu có tham vọng là có Big Data, có dữ liệu lớn, và bắt đầu có sử dụng AI để nghiên cứu xong. Thì những câu chuyện này là những câu chuyện các anh chị thấy. Bên cạnh đó thì một cái câu chuyện nữa đang bùng lên, đó là telehealth. Bây giờ luật pháp bắt đầu quan tâm để cho chúng ta thấy bà con ở vùng sâu, vùng xa, ví dụ muốn gặp thầy sĩ khó lắm, đúng mà. Nhưng telehealth thì được không? Rất được, đúng mà. Những ca khó, những cái trường hợp hướng dẫn đặt máy ban đầu nhiều khi đâu có biết đường đâu, đúng mà. Chỉ cần được hướng dẫn vài ba ca thì sẽ tốt ha. Và đây thì các anh chị, đây là những cái mà cái máy này nó có thiệt đàng hoàng chứ không phải là tôi nói dốc đâu ha. Đây là đang sử dụng ha, các nơi ở Nguyễn Trãi cũng có. Và đây là cái in-body, tức là một cái thông số giống như tôi nói hồi nãy, tức là đưa vô người ta sẽ thấy rõ ràng là ủa sao mỡ trong máu ông nhiều vậy, thấy không? Nhưng mà nói vậy sao ta biết, mà nó thành phần mỡ rồi thành phần nước, người ta tin hơn. Tức là có cái cớ. Đây anh chị thấy không, ở một cái phòng khám người ta mới ấy mà mấy người này họ thích lắm, lên mấy cô này là họ đo, họ coi, họ hỏi liền, thấy không? Rất là thích thú. Trong khi bình thường kêu họ vô khám còn lâu, đúng mà. Tôi bệnh gì đâu mà khám. Thì coi anh chị thấy ha. Đây thì cái này là cái của chúng tôi đặt ở bệnh viện Nguyễn Trãi ha. Và đây là nó lồng ghép vô trong cái hồ sơ sức khỏe học gia đình của chúng tôi ha. Và đây thì như vậy, thì đây chúng ta thấy có cái ca lâm sàng gọn để các anh chị thấy, để thấy nguy cơ phân tầng đúng. Thì chúng ta sẽ có nhiều câu chuyện và chúng ta sẽ đánh giá nhiều yếu tố nguy cơ. Tại sao nó chưa được áp dụng rộng rãi? Tại vì nó chưa có thói quen chị, các bác sĩ cũng chưa có cái thói quen, bệnh viện thì quá tải. Và như vậy thì cái hội tim mạch cũng cho phép hội bác sĩ gia đình sử dụng cái chương trình đánh giá sớm yếu tố nguy cơ tim mạch. Thì cái này đã có ở trên các cái phần mềm, kể cả tài liệu. Các anh chị thấy ở đây các tài liệu cái slide thì là diện quen rồi, tôi cũng đi lướt nhanh ha. Thì các anh chị quét cái QR code thì nó sẽ có cái trên web để đánh giá. Thì đây là các cái thông số các anh chị vào, các anh chị sẽ ước lượng được cái thông tin để khuyến cáo là có hay không có đó, rối loạn mỡ máu như thế nào. Thì các anh chị thấy đây là cái mà ứng dụng thực tế. Các anh chị ở tuyến dưới thì rất là hữu ích để các anh chị có thể hỗ trợ kiểm soát sớm. Và đây tôi cũng đã tập huấn tại Vĩnh Long. Tôi thầy Vinh với thầy cô cũng tập huấn, đây là tài liệu để ở trên bàn hoặc là dùng trên cái câu chuyện. Thì mong rằng chúng ta hãy bắt tay vào việc. Với chương trình của thầy Toàn vừa mới báo tiền đái tháo đường và bắt đầu đánh giá nguy cơ tim mạch, thì đây là công cụ mạnh để quý thầy cô anh chị chúng ta bắt đầu tại các nơi có chăm sóc ban đầu, kể cả trạm y tế, vì đó là cái gì mời gọi và lôi cuốn được người khỏe đến với mình, và khi họ tới với mình thì họ có cơ hội để họ biết được có nguy cơ hay không, thì rất là quan trọng. Thì cảm ơn thầy cô các anh chị ha.
Yeah, thank you to our Vietnamese colleague for watching the Karimi presentation. Please complete the post-webinar quiz to receive your CMB points. On behalf of the organizing committee, I extend my sincere appreciation to all of the participants. We look forward to welcoming all of you for our upcoming CME program. Thank you one more time. I'm grateful. Thanks for all of your participants, and see you in the next meeting.